All right, I'll get going.
So welcome to the diner. It's been 2 months, thanks to Dr. Amber Van Laar and Dr. Victor Van Laar. Dr. Amber Van Laar will be starting a new, we're going to call it a series. She'll be talking about medications. And Dr. Van Laar will be starting with levodopa and levodopa containing drugs today with a little history lesson. And please keep in mind that Dr. Amber Van Laar cannot give personal advice. This is meant to be more of a tutorial on these medications, how we use them and why. So thanks for joining us, and take it away, Dr. Van Laar.
Well, thanks everybody. I do not have my better half with me today. So he's out for the sake of science today. But this is why part of why I thought it would be a good idea to jump into more clinical medicine type of discussion today. As Casey just mentioned, as much as I know everyone's going to want to ask about their medication regimen that they're on, I really want this to be an explanation of what it is that we're using and why. I think the history of how we got here is, I'm biased, but I think it's actually quite interesting to dig into how we got the name Parkinson's and how we figured out levodopa. So there's a little bit of history and just education. I really want everyone to kind of just take away some of the deeper understanding of the medicines that we have. If there's any questions about a particular drug you're on or how you want to change it, this needs to be with your physician. Just to make sure that everything's safe for you personally. Just a little disclaimer. Of course. So,
you want to be on there? No. Oh, okay.
So it turns out that if you look at really ancient texts, that both Indian and ancient Chinese medicine texts, that there are actually pretty good descriptions of what really looks to be Parkinson's disease. I saw dates going back to 1000 BC. I found some other dates dating going back to like 5000 BC. There's even some description on hieroglyphs in ancient Egypt ruins that there's what looks to be someone with Parkinson. So I think that this has definitely been a disease that has followed us. It's not necessarily new. But it really wasn't until this guy over here, Mr. James Parkinson, Dr. James Parkinson, finally wrote an essay that really described this disease. And it wasn't actually named after him for another 50 years. But this was the really pivotal description, this essay on the shaking palsy that was written in 1817 and was considered a real groundbreaking description of what we now know as Parkinson's disease. I think it's also, it's a good read if you haven't read it all the way through. It's interesting because he gives a lot of insights as to how he thought Parkinson's came about, how it should be treated. And it, back in 1817, it was a fairly bold statement, but he actually describes that he's expecting that we'll have some way of treating this in the not too distant future. Another interesting finding if you have to read the text, but he actually thought and recognized that it made a lot of sense to try and treat Parkinson's early when it was still, what he said, just in the arms or just on one side of the body. And I think, we still have a lot of thinking like that today, that if we can kind of stop Parkinson's where it's at and not so severe and not so bothersome, that would be pretty revolutionary. And he even had the same thoughts back in the 1800s. I thought that was really fascinating. So he describes this in early 1800s, and many years go by without any really effective therapy. A lot of things were tried, don't get me wrong, but really nothing came along for another 50 or so years. So it wasn't really until up until the 1860s, the treatments that were there were really rough. They were hard to tolerate. They didn't work very well. And in some cases, they were actually kind of dangerous. And so here's just a list of a few things. So, I mean, it was maybe not surprisingly bloodletting and leaching and trying blistering to pull the wrong humors out of the body, things like this. But there are actually some interesting history behind what medicines were being used. So things like belladonna, other nightshade plants, rye-based drugs, In fact, some of the medicines we use today are actually based off of some of the benefit that people were seeing with some of these very medications. So the rye-based drugs, for example, this is where we actually got dopamine agonists. So I think that they weren't wrong, but of course, these are very, they're not purified. And so there's a lot of side effects and just didn't work very well. But there are other things tried, like heavy metals, iron, for example. Mercury was another treatment, strychnine. I mean, these are just really, we can look at it now and be like, what were they thinking? But they were just trying anything that they could. If they found something was helpful in some other condition, they were throwing it at Parkinson's, because it, for a long time, we're saying over, many, many years, felt like there was nothing that was really helpful. But there are some other interesting things that were tried, like the vibratory chair and this helmet. It was interesting. There was mention of patients that were in carriage rides, and they felt that the vibration of being in the carriage actually helped to reduce their tremor. And so they created these chairs, and it sounds like it actually does help. And but the benefit was very short-lived. So I think it's just kind of a interesting thing. And in fact, we have these gloves and things like this now that maybe have some sort of similar effect where they counteract the tremor that's happening in the hands to give some benefit. So it's not totally out there, but again, I think it really shows sort of the desperation of the time to find something to help these patients. I have this over here. This is actually a prescription that was written by Charcot. He's a really famous neurologist that was based in France. And he's writing to his friend, basically giving a prescription for, I think it was belladonna, something like this, to give to recommended their patients. And again, just a real need amongst the community of neurologists trying to do anything that they can to help Parkinson's patients. Oops. Oh boy, wrong button, sorry. Okay. All right. So, and again, we had 1817. That's though we have clear descriptions of Parkinson's before this, it wasn't until his article in 1817, and it was a few years after that that the name Parkinson's disease was identified and named by Charcot, who I just mentioned earlier. Many years go by, lots of things are tried, lots of things are failing. And it really wasn't for another 150 years. So in 1967 to the day, this George Cosius discovered that levodopa was a thing that was actually helping animals in animal studies that he was doing with when they were treated with levodopa, and helped to reverse the symptoms that he was seeing in these animals. 150 years after we've identified this. So, I think, one of my first questions is, why did this take so long? I really like this timeline. I think this is only part of the timeline, but you can see, here it's 1817. It took many years before we even called it Parkinson's disease, and even more years until we figured out that it was where the problems were in the brain. So this was the gentleman, Brassard, who identified that it was actually the substantia nigra. So this part of the brain that was being damaged in Parkinson's disease. But it really wasn't until we get into more modern times in the 1960s that we identified that it was dopamine that was missing in the brain. And even longer before we figured out that levodopa was the way to then alleviate that loss of dopamine. And many years since then, even to today, and part of what we're going to discuss later today is, we really haven't done much more than just changing how we're giving levodopa. I think it speaks to how well it works, but a lot of effort has been going into everything we can to just change and improve what we've done with levodopa. So how did we get here? Again, I think one of the first and most important steps was just simply recognizing that it was those cells in the substantia nigra that were lost in Parkinson's disease. And that was that was a big leap, is that you had to find the pathology in the brain that could explain what we were seeing clinically. And so just to make sure we're all using the same idea here, So we're looking as if we were going to look at this side of the brain. This is part of the brain stem. So this part of the brain stem is called the midbrain. So it sits right in the middle. And if you continue this down, this would connect with the spinal cord. So when we look at someone without Parkinson's disease, if you age enough, you get these really dark pigmentation here in this part of the substantia nigra. This is where the dopamine cells live. The cell bodies are here in the substantia nigra. And it's their death, the loss of these cells, that we can see even just with your eye from even far away. There is less dark staining here, and it's because these cells are missing. And it's unfortunate because those are the cells that are making the dopamine that then controls things like movement. And this was a really important part of trying to figure out what is Parkinson's. So this was an important step. So then the next leap was to say, gee, these are the cells that are missing, but these are the cells that are making something called dopamine. So just identifying the chemical dopamine was another major step forward. Since then, we've come to realize there are a lot of other what we call neurotransmitters. These are brain chemicals that are used for cells to communicate to each other within the brain. So it's not just dopamine that's affected. There are several others, but dopamine's the big kahuna for Parkinson's because it really is important for control of motor symptoms. So just a little bit more like what is dopamine? Like what does it do? So dopamine modifies a lot of different things in the body. So there's a lot of physical functions and then also behavioral functions that dopamine can play a role in how these turn out. So I think what we're talking about today is really the control of movement. So dopamine is really important for modifying how the movement is actually done, how it comes out. And this is what we know is a big problem for patients with Parkinson's. But it turns out, there are other things that we can't see quite as well. So motivation can be dramatically affected by dopamine levels. And I think a lot of you may have experienced this, though it's a more subtle feature that not everyone has problems with. But dopamine also has a big role in things like arousal and attention. But then other major physical functions, like it's needed for lactation. But other parts of dopamine other functions of dopamine that I think are really popular out in the community are things like its reward and gratification. There's a lot of positive feedback that we get from dopamine, depending on what parts of the brain are being affected by dopamine. And so there's things like addiction and things like this can be a big problem with dopamine, but not for everybody. So just to kind of give you a sense of, there's a lot of different things that dopamine can do. Really, we're going to be focusing on the control of movement for when we're talking about Parkinson's. So another key step in getting us to where we are today was realizing that levodopa, not dopamine, not serotonin precursors, but levodopa was really key in improving those motor symptoms. So a lot of this was figured out, again, using animal models. So there are ways of giving toxins that deplete things like dopamine and serotonin. And when they did this in animals and then gave back just levodopa, they discovered that there was a big improvement in their ability for these animals to move around. Now, when they first started giving levodopa to patients directly, they started moving around and then they started vomiting profusely. And so they quickly realized that in order to get high enough doses of levodopa to relieve and improve the motor symptoms, it then came with a really bad side effect of vomiting. So another term for vomiting is emesis. And so the name Sinemet means synemesis, or without throwing up. And what the big difference was then figuring out finally that we needed to add carbidopa with levodopa in order to help prevent some of these really unpleasant side effects. And this was where we got to where we are today. And honestly, this is where we've been since the 60s. Nixon was president. We just went to the moon, and this is how long we've been using this kind of medication, even to this day. So why levodopa? So bear with me. We're going to do a little bit of biochemistry here. So we cannot give just straight up dopamine. If you take it by mouth, it causes a lot of problems with blood pressure and vomiting again. It can't get past the blood-brain barrier. So our brains are very special. They're privileged. Not everything that you put into your body will go to your brain. And that's great. We want to have that level of protection when it comes to your brain. It's a problem though when we want to get drugs to the brain to help treat certain things, and dopamine isn't it. So we can't just do a direct replacement with dopamine. And so what we have found is that levodopa can cross the blood-brain barrier, and by just the normal machinery that all of our dopamine cells have, it takes that levodopa and then processes it right into dopamine. Now, we had to add this carbidopa so that we can improve the amount of levodopa that's getting into the brain. And this helps more of just plain levodopa get up there. So carbidopa doesn't get absorbed into the brain, but it helps prevent the breakdown of levodopa in the bloodstream. And so this is how we can really increase the levels of levodopa and improve the chances of that then being made into dopamine. And more when you don't have dopamine, that's what causes the tremors, the stiffness, the slowness, and all these symptoms that you all know so well. And it's only when we can relieve this with increased dopamine that we can help to improve these motor symptoms, and mostly motor symptoms. So we have lots of types of levodopa. It's been, again, pretty clear that we need to add something with the levodopa in order to make sure, again, the levels are getting high enough up in the brain without being broken down in the bloodstream. And this is how we came to carbidopa, levodopa. Many of us here know this as Sinemet, and there's also controlled release Sinemet. It's called different things in different countries outside of the US, but this is the one that I think we all know so well. And then over the years, there's just been these continued trials to improve things. So Sinemet CR came out, I think, in the 90s. And the idea here was that if it was controlled release, that we would get a nice, more even absorption of the Sinemet. And in fact, it really hasn't panned out. Sinemet CR is, not quite as reliable as something like just regular Sinemet, where you take it, you kind of know when to expect it to kick in. The Sinemet CR does not do that as well for everybody. And this is why we typically give it at night. So we don't, it's a bit easier to get up in the morning for some people if they've had the Sinemet CR at night. But, there's been a big desire, because Sinemet just doesn't last very long for a lot of people, that there's been a big need to try to extend and make it last longer. And this is how we came, this is how reitari came into development. So again, really trying to change the way that the pills are made so that they are absorbed more slowly, so that we can get a more continuous benefit and not having to take so many pills so many times a day. I think this has not been such a slam dunk as I think we were all hoping with something like reitari. There's a lot of work going in. Again, it's all about the packaging and how levodopa is put together and how it's absorbed in the body, again, with these big goals of trying to really stretch this out over time. Then in addition to that, and I want to go into some of these other therapies in further presentations down the road, but there was an attempt with using something like a COMT inhibitor. So COMT is a way, when you've made dopamine and it gets out into this space, it can't just sit there. It has to get metabolized, or it has to get taken back up into the cell that it came from. And in some cases, COMT is sitting here in this space, and it will metabolize or break down the dopamine. And so one way to keep dopamine sitting here so that it's effective is that you block this COMT so that the dopamine can just sit in the synapse and do its job a little bit longer. And that's how we came up with something like Stalevo. So to make things even more complicated, Stalevo is 3 different drugs. So we have carbidopa, levodopa, and entacapone. So this is the COMT inhibitor. And again, the idea here is when you take all of these together, the benefit is to really extend how long that levodopa can have an effect on motor symptoms. I just want to pause real quick and just see if there's any questions on levodopa or what we've discussed so far.
Amber, this is Christine. I have a question. How knowledgeable, I know you may be slightly biased, but how knowledgeable do you think general neurologists are about the differences in just these few drugs that you've mentioned here and how to use them?
It's a really good question. And I got to say, it's highly variable. And I think they may know of them and the doses and, maybe when they should be used. But the really fine control over these medications, that's really why there's such a benefit of having a movement disorder specialist. These are really nuanced and subtle changes that can be made that will make a big difference for patients. And I think that is definitely a specialty that movement specialists are really good at. Any other questions right now?
There's a comment in the chat. So there was Parkinson's before current day environmental pollution and toxins? Absolutely.
And that's actually part of why I wanted to put that there. It was kind of mind blowing for me when I realized that this is not a modern phenomenon. Parkinson's has been around forever. And, talking to, there's a really famous neurologist, his name is Chris Getz. He's in Chicago at Rush. Had a chance to talk with him for a while. And his belief is that just because of how the human brain has evolved over time, that we're always going to be prone to potentially having something like Parkinson's just because of how we've evolved. And so I think the fact that we can find evidence of this, way back in the day just speaks to, it's just a part of our condition and the vulnerability of dopamine neurons to over time. And perhaps there's been an increase in number of cases of Parkinson's because of these environmental toxins. But by no means is this a new disease, that's for sure.
Another question, how long has Stalevo been on the market?
I'd have to go back and check for sure, but I'm thinking like late 90s, early 2000s.
Okay.
So yeah, before reitari for sure.
And then why did Merck stop producing Sinemet CR? Because the other versions we use today, like Sinemet ER, don't work as well.
Yeah, that was, gosh, I remember being in clinic one day and it was like, what? It's a really good question. There was a big shift just a couple of years ago where a lot of these like longer acting formulations, the insurances just weren't covering it. And I can only speculate as to why that happened. But it was a real disappointment. There were other drugs, not just Sinemet CR. There were other things that were affected around the same time. I'm not really sure why the insurances were making this big shift. I feel like it's changing a bit again. I think reitari is another good example of getting away from that. But that was a big surprise. I'm not really sure. In general, these extended release formulations of Sinemet just don't work quite as well, but I don't know. I'm not sure what the motivation was behind the loss of CR.
I think that's it for now.
Okay, all right. Yeah, keep the questions coming in. No, there should be time at the end too.
How long has it been on? No.
One more question, Amber.
Oh, yep.
My step grandmother lived on Manhattan Island, New York City, and in the 1950s was diagnosed with PD. I remember being told she was the 7th person who'd had an experimental surgery that could cure her PD, but left her unable to swallow. She lived out her life on powdered milk and eggs that would just slide down her throat. Were you aware of this surgery?
So there were in early days, and I think we might have it on this earlier slide. So as far back as the 80s, there were fetal cell transplants being done. That was fraught with a lot of problems. And then somewhere in here, there were also ablative surgeries. Can you guys hear me?
Let us mute some
Hello?
folks.
There we go. So there were what we call ablative surgeries that I think might have been done in that around that time. So they actually would go and like burn a part of the brain, and it was great for tremors. So it was really good at calming mostly tremors down, but by no means was a cure, I think, by the way we would define it today, at the very least. There are, it's, you know, I think a lot of the way I think about these things, when you destroy part of the brain, it ain't coming back. And so I tend to kind of be wary of ablative surgeries. They can work. There's obviously side effects. It's still a procedure involved. So I take it with a grain of salt, but things have been done surgically for Parkinson's for many, many years. I think it's kind of surprising when we look back, and it gives us a little bit of humility today. Let's put it that way.
One more question asking for a little more discussion about reitari and what exactly it is.
Yeah, I should have pulled up a picture, but reitari is a way of, it's actually it's like all in one capsule. But the idea is that there is immediate release Cinemet, basically carbidopa levodopa, that can be released right away. So you get that same little boost that you get when you take just regular Cinemet or carbidopa levodopa. But then it also contains another portion of the capsule contains basically little beads that then have slower release of levodopa, so that you can get a more sustained benefit over longer periods of time. So it's, again, sort of a way of just packaging the carbidopa levodopa, so that, again, the point is to have it last longer. Now, I got to say, when this first rolled out, it maybe didn't hold up to all of our hopes. It seemed like people were still using a lot of the same number of pills a day. But it looks like they are trying to improve upon this even further to, again, the whole point is extend the benefit of the levodopa.
Okay, we have another one that came to us via email. Why doesn't carbidopa levodopa medication work? It's been on the market for years. The other medications like Ongentys, Nupro, Comtan have tons of side effects. They don't work either.
Well, I gotta say, I think it works pretty well for most people. There's a vast majority of patients with Parkinson's will have some degree of benefit with carbidopa levodopa. Everything has side effects, and we're going to get into that here in a little bit. But I think the other big takeaway that I'm going to really push home today is that everybody's different. That's why we can't give recommendations across the board. Everybody's Parkinson's is different. Everybody responds to these medications differently. That's why these need to be tailored medications for every single person. The side effects that are mentioned here, yes, this is a big issue, and it's even more of a problem as Parkinson's progresses. So there's a lot of effort in trying to improve on the medicines that we have, but then also trying to help with things that, like what we're doing with gene therapy, to prevent this from getting to that place and getting there in the first place.
One more question. Back in ancient times, there was wheat. Is there any evidence that Parkinson's and other brain diseases are caused by gluten protein buildups in other parts of the body?
That evidence just isn't there. I will say, not all cultures had gluten containing materials, and they're still Parkinson's. So a lot of it, I think that kind of argues against it. Anecdotally, I've had patients who have gone gluten-free and maybe they've experienced some benefits or some improvement in the responsiveness to their medications, but I just can't blame all of this on gluten.
Okay, I think that's it for now.
Keep them coming. We'll just keep going through. So kind of in the line with what we were talking about previously with the GI issues with Parkinson's, when the stomach gets really stiff and it's not digesting as well, and again, we were talking before about the bacteria that are there. There's just lots of reasons that even with diet, that the medications that you take by mouth when they get into the stomach, just because of what's going on with the GI tract, they just don't work as well. So it's kind of feeding into one of these earlier questions about why they don't work. And sometimes it's just because we can't absorb it as well because of the problems with Parkinson's in the gut. And so there have been a lot of efforts to try to get away from taking medicines by mouth to just really try to bypass some of these issues altogether. So one that's sort of close to this, and some of you may be familiar with it, it's the Duopa. So this is one way where you are basically bypassing the stomach where a lot of these problems may be occurring. And you have this tube that's inserted, and this is actually used in a lot of other GI type of conditions. You get this tiny little thin tube, and it's delivering the medicine near the jejunum. So this is the part of the intestine where most of your medications and other dietary needs are. This is where the absorption occurs in this really early portion of the small intestine. And so by bypassing the stomach and this, you're avoiding a lot of issues with diet and things like this. It's right there at the source where it can be taken up right away. And so for a lot of people, this is a nice way of getting more continuous levodopa being delivered right to the spot that matters. So this is in a gel form. So it's the same carbidopa levodopa, and it's in this like a clearish gel. And it comes in these cartridges, and then you fill up the cartridges, insert them into this phone-looking device. And then this connects, this is a pump, and it connects to this tube that then goes into the small intestine. And this then delivers this levodopa containing gel right to the spot. And we can adjust the dose this way. So you can change how much levodopa is going in. You can also program this pump so that when you wake up in the morning, you get like a big dose to get the day going. And then you get this continuous infusion over the most of the day. So this is not something that typically is used all day long, though there's some ways of changing it. And again, really bypassing all the issues that come when we have to take it by mouth. Again, the idea behind a lot of these medicines, that these different types of delivery systems for medicines, is to just make sure there's more levodopa sitting around longer so that we can get more dopamine being made in the brain. And that's what is meant to relieve a lot of these, the motor symptoms for longer. Interestingly, they're trying to basically make Stalevo in a way into a gel as well. So there's this, again, the three medicines all together. So it's levodopa, carbidopa, and entacapone. So this is the medicine that prevents the breakdown of levodopa. And when you give all these together, again, in a gel, in a very similar kind of pump fashion, the idea is now that we are preventing the levodopa from being broken down, can we extend the benefit even longer? And just as why would we want to keep doing this? Well, one, it's nice not to have to take medicines by mouth all the time. But the other big benefit is that, the ups and downs that happen when you take a dose and it wears off, take a dose and it wears off. This should stabilize it so that there's a more even response throughout the day. And by having less fluctuations, that also means that you're not getting the symptoms that happen when you're really off or, too on. And so it really should help to reduce things like dyskinesias, for example. So that's a big reason why we want to really extend the effects of levodopa. Now,
And Amber,
sometimes, yeah,
sorry, for people
no,
who switch to Duopa,
Mm.
how has the amount of carbidopa, levodopa impacted when you make that transition that you have to take?
Mm, mm. We actually start with what you're using now. So we use that as a basis. It's a starting place. And so I think this is part of the difficulty in adopting Duopa, because it's hard to back calculate, how to deliver this over the course of the day. So it's an issue. But we really take the medicine, take the total dose of what you're taking, we get one number, and then we try to break that down over the course of the day so that we have, so many milligrams per hour that are then being infused into the small intestine. It's modifiable, so kind of like DBS, where even patients can go in and reprogram their pump. So they have a slow day, you don't really need so much levodopa, you can turn it down, or you're like, man, this was a really stressful moment, I need more levodopa, you can get a little booster through the pump. And so I think that's been nice for some people to have that level of control over their medication. But for some people, just having this contraption and having to do the programming and the cartridges and things like this, it can be complicated. But it does give, real high level of control for patients who enjoy this. So I've had patients who were nursing, it had familiarity with this, with pumps and tubes and things like this. They were comfortable with it, but that's not the case for everybody. So though I've been talking a lot about trying to extend the benefit of levodopa and keeping it around the system longer, sometimes people will need like a rescue dose or only as needed. And that's led to the development of other drugs like Parcopa. So this is not being used quite as much, but it was considered a real rescue for some people, and some people use this only exclusively for their Parkinson's. But it's orally disintegrating, so it dissolves very quickly in the mouth. The idea is that this would again, real big hit right up front when you take Parcopa. More recently, there is a powder that you can use like an inhaler. So again, this is bypassing the stomach entirely. So you take this little inhaler, there's little capsules you put in, you twist it, and then you take a deep breath in. And what happens is it goes right into the lungs. So it turns out the lungs see a lot of blood, and that means it can easily absorb the medicine into the bloodstream, like right away without going to the stomach. And that means that the medicine can get in quickly to the bloodstream, and that means it can get quickly up to the brain. And so these are considered more like rescue or as needed medications when you need just a little bit of levodopa real quick to get to the brain. And so again, just really trying, we know levodopa works for most people. And so I hope you can appreciate a lot of efforts gone into just changing the way that we're delivering levodopa to try to get the best outcomes for patients. Before I move on from here, is there other questions that came through?
Just one comment. I believe the extended release meds are released in the circulatory system. There have been some trials where the meds were retained in the gut, gastric retention, like the accordion pill, that haven't been very successful.
Yeah, I have that coming up.
Okay.
So yeah, no, it's let's just say this is only a select few items of levodopa that this is not exhaustive list of everything. But let me just tell you, there have been a lot of people trying different things to make this work for exactly this purpose. And I think, as the mention with the accordion pill is brought up, again, trying to bypass the stomach entirely has been of great interest, and that's what we're seeing here. So how do we decide what to do? Like, how do we decide on dosing and changing of medicines? And this is sort of, I guess, maybe more my philosophy, but I think this is really what you're going to get when you see a movement specialist. So in general, if it's the first time we're meeting, I don't start medicine on everybody every time. That's not always necessary. So really rely on reports from my patients to know if they need something. For some people, their Parkinson's is really tremor. They don't have as much of the stiffness or the slowness, and certainly not enough that really bothers them at very early stages. And sometimes we would just watch. But for some people, it's clear the symptoms are really interfering with what they want to do. And that's when we really need to start talking about medicine. And in general, whatever it is that you pick, we always start at a low dose. And if you build it up slowly. It's really rare that I would make any big changes very quickly. So just try very hard to get away with the least amount of medicine for as long as possible. At the same time, trying to make sure that you're feeling the best that you can with the least amount of medication. And so, really focusing on levodopa specifically, this is a great medicine for the stiffness, the slowness, the tremors, the motor symptoms. Levodopa can help with some of the non-motor symptoms, but just doesn't work quite as well. These medicines generally don't work quite as well on things like memory. Sometimes gait, but balance doesn't really improve much. And sometimes mood doesn't, these are things that are expected to be improved with levodopa. And overall, in general, when adjustments are made, because we expect there to be changes over time just because of the progression of Parkinson's, we really are depending on your reports of how you're doing at home on a day-to-day basis, with your friends, with your family, like how is Parkinson's getting in the way or not? And this is really key for helping us to determine if and when we should make any changes. One of the key things that I always harp on with my patients is the timing. Just simply when these things are taken can dramatically change how well you do and how your symptoms are managed. So the timing is really important to review. I would argue almost every visit with your Parkinson's doctor. The other thing that would really change what we do is if there are side effects. Depending on, again, the timing of the side effects and what kind of side effects, that would could potentially significantly change what we do, or if we add anything. So those are other key things that we talk about in clinic visits. So speaking of side effects, I just want to make sure we are all on the same page. So what are the side effects of things like levodopa? So the most common ones are nausea and vomiting. Again, the name Cinemet means without throwing up. That's how the name came about. And so the idea is that with more carbidopa, that this would prevent the nausea and vomiting. And that is the case for most people, but not everybody. So one of the most common side effects is still nausea and throwing up. Blood pressure changes can really drop. So this can be experienced by people as feeling dizzy when you stand up too fast. But things like mood changes and getting confused, this can happen. Often it's a sign that maybe the dose is a little bit too high. But it can affect sleepiness, and it can both make you too sleepy and can't sleep at the same time. So there's clearly an effect of dopamine on sleep, but it can really change your appetite. I've had patients complain of things like headache. I remember getting calls like, my urine's very dark, I don't know what happened. And like, no, that's just the levodopa. So, there's kind of odd things you maybe wouldn't think about initially. But one of the more common, and we can say side effects of levodopa, is dyskinesias. So when the medicine's maybe working a little bit too well, or the dopamine levels are a little bit too high, it can then lead to dyskinesia. So it's basically extra movement. So you go from being too off where you can't move to being too on where you're maybe moving too much. And so we always check in on these sorts of side effects just to make sure that we're avoiding as much of this as we possibly can. And this is how medication changes are made. So there are a lot of what we do as movement specialists is actually trying to reduce these side effects. I think this was already brought up today that there's lots of side effects. Yes. I think we've gotten pretty good at doing our best to avoid them or treating them so that they are not as much of an issue. And again, I cannot emphasize enough that just simply changing the timing of how the doses are taken and when, it can really dramatically improve the outcomes and how you're feeling on a day-to-day basis. But it's really hard for me to change the timing if I don't know what's going on at home. And so it's really important for everybody with Parkinson's to really get in tune with your symptoms and then how they're changing over time. So, what I often tell my patients is, if you're feeling really good at some point, I want you to sit and think, like, what did I just do? How far am I from my last dose? What did I just take? What did I have for lunch? Just all these sorts of things to help you clue into how your body is reacting to these medicines. I'm always better able at making better changes if I have that information coming in. That always helps tremendously. And so the Parkinson's Foundation, Michael J. Fox, APDA, a lot of these groups have like diaries that you can fill out. These are really helpful for patients and your doctors to get a sense of when things are good, when things are not so good, in order to make better changes to help you feel better. So keep that in mind. There's a lot of strategies that we use specifically for nausea, because this can be a really common problem for people, even with carbidopa. So taking a small carbohydrate type of meal when you're taking the Cinemet. So again, crackers, some dry cereals, again, something without that protein that we've talked about before. That's a great way to help prevent the nausea, but also without blocking the absorption of your Cinemet. So that's one technique we use a lot. And sometimes for some people, we actually give extra carbidopa. It's also called Lodocin. And so this would be an extra pill that you take with something like Cinemet. And it's really good at blocking the nausea that may happen. And it can also block some of the other side effects that come up with levodopa. And I think this is a really important, this is a strategy I used a lot, because when we start really low and we build up very slowly, if you're starting with like a half tablet of Cinemet, that means you're also getting half of the carbidopa. And so for some people, when they're just starting a medication, just starting something like Cinemet at those first few weeks, sometimes extra carbidopa will make the difference and allow us to get the Cinemet up to a high enough dose that levodopa can actually work. And so to keep this in mind is a great way to help with things like nausea. And sometimes we need to add other medicines or change other medicines that are being used for Parkinson's. This can help minimize side effects, help make the medicine last longer, and maybe sometimes even work better. And that's so like the COMT inhibitors, like entacapone, they help the levodopa work a little bit better. And that sometimes we need to add other medicines to help specifically with things like dyskinesias. Sometimes we need to increase the dose high enough so that we can get the benefit on tremors and the slowness. But sometimes you get dyskinesias, and there are ways for us to change meds or add medications to help minimize the amount of dyskinesias. So before I go into the new things for levodopa, are there any questions, or do you want to save them for the end?
We have one question. How does exercise affect dopamine in the brain? I have heard that exercise uses up the existing dopamine in the brain more efficiently. Does it also help the dopamine cells not to die? Does it generate dopamine or use it up faster?
It's a really good question. It makes me think it's another topic for discussion. So there is a lot of reasons to think that dopamine is being used up when you move. Just that in order to move, you need dopamine. And so with exercise, it's a lot of like intentional movement. And yes, it can use up dopamine. Now, what patients are telling me is that oftentimes if they know they're going to the gym, they make sure that their medicine is working well when they go to the gym. It helps them work out better, and they don't feel quite as bad when they're done exercising. Now, typically, yes, you may feel really depleted after exercising, but there's, pretty good evidence to suggest that the rebound is better with exercise, and the benefits over time with exercise seems to help just overall boost levels of dopamine. I had a patient who he would exercise, in order to feel that little bit of boost with dopamine. And so I think the benefits of exercise are really not on dopamine itself, but there's some evidence to suggest that when you exercise, you actually can boost growth factors in the brain and maybe things like this, or you help modify the immune system so that the exercise is actually affecting other aspects of Parkinson's that help the cells live longer, and not because of dopamine, but because of other things going on.
We have another question. What are the dangers of carbidopa, levodopa, and signs of overdose?
Yeah, it's a good question. I think one of the kind of in line with that question is, well, how much is too much? I get asked this an awful lot. And again, this is what people are taking, and the doses are so variable that, there's, we really give you as much that we see that is needed in order to get the benefit. Now, if the medication is too much for where you are in regards to your Parkinson's, usually this comes out as things like getting really confused. These are all symptoms of dopamine being too high. So you can get really confused. It can even cause things like hallucinations. This is where dyskinesias come into play. So these involuntary movements where you have a lot of extra movement going on. So you look really fidgety. Those are the big things. Blood pressure issues can be a big problem. So it's not subtle. Let's put it that way. If the levodopa dose is too high, but it's hard to overdose on by accident. This is most people don't feel good when the medicine's too high. I just wanted to go over just a few new things that where levodopa is heading. So this is again like reitari in that it's another pill that's really designed to give some immediate release levodopa, but then has some parts of the capsule that have slow release of levodopa, so that you can get the benefits of immediate release and controlled release in the same pill. The hope is that this will limit the number of pills and the number of times a day people have to take medication. And this is still in study, so it's not quite here yet. The accordion pill was just brought up. Man, I thought this was a beautiful idea. It makes a lot of sense in some ways. The idea is that you take a capsule that has the medicine on this material that's folded up really tight inside of a capsule. The capsule dissolves in the stomach, and all you're left with then is this material that's all folded up, and it slowly opens and unfolds inside the stomach. And as it unfolds, it slowly releases the levodopa, again, with the goal of extending the release of and the benefit of levodopa over longer periods of time. This has been in development for an awfully long time, as I think was pointed out. I think it's a great idea. This is just a whole new way of delivering medicine that still needs a lot of kinks to be worked out. And I think that with all these other medicines that we've talked about and all the things coming down the pipeline, this has fallen out of favor. But this is another one I think is still being looked at. As I mentioned earlier, this desire to just bypass the mouth entirely has been where I've seen a lot of shift of interest in new ways of delivering levodopa. And so there's been a lot of interest in transdermal or subcutaneous. So you're going in or under the skin to deliver levodopa. And the point is that we can bypass the stomach entirely this way. And by doing so, this improves like how reliable we are with absorbing the levodopa. And again, the real benefit here is that we're reducing these big fluctuations between doses by having a steady level of levodopa over the course of the day. So one of these is this ABBV 951. So this is a pump patch. So there's not very many pictures on that we can find of this, but ideally this is, kind of like an insulin patch that, sits on the skin and delivers levodopa right into your skin, with the idea that this would give you coverage over a 24-hour span of time. So I think the goal would be, to get rid of pills entirely. Swallowing can be a big issue for a lot of patients. And again, the absorption's an issue as well. And so I think there's a lot of hope that this will work out well. One of the problems with all of these delivery methods is levodopa itself. It tends to not like to be in liquid, and it tends to be really hard to absorb through the skin. And so a lot of work has gone into changing levodopa just a little bit so that it can actually be delivered as a liquid and taken up more readily. Another pump that we see here, so there's a belt pump and a patch, and this neuroderm, there's all these methods to try to deliver levodopa in a more continuous way. And I think learning a lot of lessons from like diabetes, for example, to take advantage of a lot of the devices developed for that. So I expect to see these things come to market pretty soon, actually. So just a few takeaways. No two patients with Parkinson's are the same. Everybody is on something slightly different. And really, the core function as a movement specialist is to tailor Parkinson's medications to every single person. So I think it's really, a lot of people are apt to ask their buddy, like, what are you on? What are you taking? And just know that what you're taking is, really should be unique to you, and don't feel bad if you're not on something someone else is. Now, another big thing is we anticipate that changes are going to be needed over time. This is just the nature of Parkinson's. And this is one big reason I would say you should be working with a Parkinson's specialist, because they are going to be the ones who are going to be best at knowing when and how to change Parkinson's medications, and really let you, the patient, drive, how this happens. Unfortunately, this does mean sometimes there's trial and error. There are some medicines that are going to work great for you and not someone else. And, I think, there's some period where, especially with big changes, that there may be some trial and error or adjustments that may be needed over time. But this is, again, why it's really important for you to work with your Parkinson's doctors or your other medical teams for your Parkinson's to find what's best for you and for you at that moment. And so please talk to your doctors. Okay, that was it. What questions do you have now?
Just one comment. The very things that you just talked about, Amber, are the reasons why we are loath to see people share dosages and in support groups or online with each other, because everyone is so different and it scares the heck out of us.
Yep. So be cautious. Talk with your doctor.
Yep. Here's a
Can't say it
question.
enough. Yep.
If you can deliver levodopa in a continuous way, will the substantia nigra always be able to use it?
So the underlying problem here is that Parkinson's is continuing to damage those dopamine cells in the substantia nigra. So the cells that are there should still be able to use levodopa. And there's no real benefit in having, pills that come off and on. There's no reason for us to think that just because we move to a more continuous infusion that the cells would not be able to handle it. In fact, there's a lot of benefit. There's some evidence to suggest that having more even levels throughout the day may actually be healthier for the cells, because they're not constantly going up and down.
Amber, with regard to the previous slide in the subcutaneous and patch pumps, like they use in diabetes, is there a way to monitor dopamine levels like someone would monitor their blood sugars?
No, I mean, not by like a blood test, let's say, not easily. And these are not intended to do that. That being said, one of the best ways is just, looking at the patient and just knowing how you feel clinically is what I would say is the best judgment of how much is there. The other thing to keep in mind is, it's what's in the bloodstream. It doesn't really help me as much as knowing what's in the brain. There's no good way for us to easily find out how much dopamine is floating around in the brain.
Okay, thanks.
It looks like that's all of our questions. Oh, wait.
Well,
Does dopamine have a negative feedback effect like cortisone and the adrenal gland?
So that's a really complicated question. Let me see if I can answer it quickly. Just having Parkinson's and having those cells die, there is basically the receptors on the outside of the cell that sense dopamine out in the environment. When those cells are dying and there's less dopamine around, those receptors are really increased. And so the cells are just trying to grab every little molecule of dopamine they possibly can. And so that can have an impact on how much dopamine is being produced, let's say. And so when you now have a bunch of dopamine that's more available, because now we've started medicine, you can see, decreases in how well and how many receptors the brain is using to grab the dopamine. And that can affect it. Over time, that will stabilize. And so I think you're more likely to see these effects with changes in medications, but we expect this to stabilize over time. Hopefully that was simple enough.
Any insights into improving sleep?
I'm going to keep this focused on the levodopa side of things. Yes, sometimes it means that you need a little something before bed. So this is where like the Cinemet CR came into play. This would be like a bedtime dose that's just enough to kind of get you through the evening. Sometimes there's a lot of other strategies. Duopa is another one. Having DBS turned on is another one. The reitari, again, another way of just giving a little bit of levodopa to last through the night. Patients have come up with some really, really amazing things to help with this as well. But those are the early suggestions. I don't like people setting an alarm and waking up to take medicine, though, but that's not a good idea if we can avoid it.
Why does DBS reduce the level of dopamine you need?
I think we're going to conclude.
I do want to. I think DBS might be a good topic for later.
Yeah.
We can get into it then. Yeah. But I do need to get to another call.
Yeah, lots of thank yous, Amber.
Oh my gosh.
Thank
Yeah, my
Thank
pleasure.
you.
We'll see you on Friday, December 17th.
Sounds good.
Thank you.
Every weekend, everyone.
And see you
Bye.
tomorrow at the symposium, perhaps 11 to 1. You can still sign up. Go onto our website.
Just come.
Bye.
Bye, everyone.
Bye. Tell Victor we said hello and hope his poster judging went well.
David, real good to have you back in saddle.
What's that? I'm sorry.
Good to have you back in the saddle.
Well, little by little, huh?
Good to see you, David.
Good to see
No, it's
you.
nice. It's nice being here. And I'm glad Casey and Christine and Emily are doing such a wonderful job of keeping things on track. Probably better than when I was there. So.
Do we have to register for the symposium? And it's not too late to do that though, right?
Yeah, you need to, so you can get the link. Yeah.
Okay.
And even though, it kind of takes you through checkout and everything, there's no cost to it. It's just the way the program is set up that you have to go through that. But there's no cost. But to get the link, you have to register.
Okay, great. Yep. Okay.
Well, it's
Great
good seeing you.
program. Doctors programs. And you do a good job, David. You always do our research for us.
Well, I'm glad I can still be engaged with everything and everybody.
Right. You're looking good. Keep up the good work.
Well, rely on the medical folks.
Yep. Okay, I'll see everybody.
Okay, goodbye.